Okay, I think we better get started so we give Dr. Brown enough time. So hello and welcome to the annual Beckman-Brown Lecture on Interdisciplinary Science. I'm Diane Beck, a professor in psychology in the Neuroscience program. I've been a member of the Beckman Institute community for 18 years now, and it's my pleasure to welcome you here today. So the Beckman-Brown Lecture on Interdisciplinary Science honors the late Arnold Beckman, and the founder of the Institute, and Dr. Ted Brown, the Institute's founding director. The Arnold and Mabel Beckman Foundation endowed this lecture series, as well as a Beckman-Brown postdoctoral fellowship to celebrate both Arnold and Ted. The 2023 Beckman-Brown Fellow is Kelly Powderly, and she is here in the audience. We can give her a welcome. So in the past, we've been lucky enough to have Ted attend these talks and give his own introduction. Unfortunately, he's unable to attend today, and so I'm going to summarize some of the remarks he has made in the past. He reminded us of the incredible generosity of Arnold and Mabel Beckman and their foundation in supporting the Beckman Institute. The Beckman Institute is a large, beautiful building designed to bring people together. It is also a community that has worked hard to change the way siloed departments and, more importantly, researchers think about collaboration. The Beckman Institute is all about bringing together people to cross disciplines and break barriers. And the Foundation has been a strong partner in this work. Today, I am pleased to introduce Professor Emery Brown as this year's Beckman-Brown Lecturer. His work exemplifies that cross-disciplinary and boundary-breaking science that Beckman Institute holds as a core value. He is the Edward Hood Taplin Professor of Medical Engineering and Computational Neuroscience at MIT. He is the Warren M. Zapol Professor of Anesthesia at Harvard Medical School and an anesthesiologist at Massachusetts General Hospital. He earned a BA in Applied Mathematics from Harvard College, his MA and PhD in Statistics from Harvard University, and his MD from Harvard Medical School. Professor Brown completed his internship in internal medicine at the Brigham and Women's Hospital and his anesthesiology residency at Massachusetts General Hospital. He's one of the few people who are members of 3 national academies: the U.S. National Academy of Medicine, the National Academy of Sciences, and the National Academy of Engineering. He is also a fellow of IEEE, the American Association for the Advancement of Science, the American Academy of Arts and Sciences, and the National Academy of Inventors. He is a true boundary crosser. Although he has used his considerable engineering and statistical skills to tackle a number of questions in neuroscience, he's particularly interested in understanding how the state of general anesthesia is induced and maintained, and it is this work that he will be telling us about today. So please join me in welcoming Professor Brown.
Great, so thank you so much for the kind introduction. It's a real pleasure to be here. It's not beyond a pleasure, it's an honor. Thank you so much. I've known about the Beckman Institute for a number of years, and it's as impressive as I thought it was, so outstanding. So I'm going to talk about general anesthesia, neuromodulation, altered states of arousal. And this is the funding support that I've had from NIH, from my departments at MGH, and also at MIT. And these are my colleagues, so Patrick Purdon, who's now at Stanford, Nancy Coppell, who's a mathematician who's at Boston University, Shuna Keju, who is actually the chair of anesthesia at Mass General, Ken Salt, who's an anesthesiologist at Mass General, Laura Lewis, one of our former PhD students who's now back on the faculty at MIT, Earl Miller, my colleague at MIT, Miriam Shinechi, who is one of my former PhD students and postdoc who's now at USC, Shenung Cheng, former postdoc who's at WashU, Ahmad Eskandar, neurosurgeon who's now down at Einstein, Jake Donahue, who's a PhD student, Suresh Chakrabarty, postdoc, and Sid Cash, neurologist at MGH. So what I'm going to do is, this is the outline I'm going to follow. I'm going to talk about a common feature of anesthesia drugs, which is they produce slow delta oscillations. Then I'm going to share with you a few what I call anesthetic factoids, just things any educated person in science should know about anesthesia, just so they're edified. And then I'm going to speak specifically about multimodal general anesthesia, closed-loop controlled general anesthesia, and reanimation. So what is general anesthesia? So it's a drug-induced reversible state that consists of antinociception, meaning you don't process pain, you're unconscious, you don't form memories, you're not moving around, it makes it easier for the surgeons to operate, and you have physiologic stability. So the reversible here is really important because if you take these four things here by themselves, they're synonymous with death, and that's not cool. All right. So this is what we do as anesthesiologists. But as we do this, it's very often said that it's not clear how anesthesia works, so nothing could be further from the truth. How it works is no mystery. And I'll just tell you right now in 2 sentences, as I'm going to show you, the drugs create oscillations. The oscillations impair the ability of the various parts of the brain to communicate, and you generate states of hallucination or unconsciousness. I mean, that's basically what's going on. And so, and that's going to be a recurrent theme through what I show you here today. So let's talk about one of the main oscillations that the drugs actually do produce, these slow delta oscillations, all right? So to start this off, I want to go back to some work that was done by Frederick Bremet. This is a cartoon based on Bremet's work that he did in 1935. He was a Belgian neurophysiologist, and he did a set of experiments in cats where in the first set of experiments, he transected the spinal cord here and then separated the brainstem and brain. And when he measured the EEG in the cats, he saw something look like that. It looked an awake appearing EEG, and he called it the encephale isolé, or the isolated encephalon. Then in a second set of experiments, he transected what is most of the brainstem here from the cerebrum, and he again measured the EEG, and he saw these oscillations like this, very large, sort of slow oscillations, and he called that the cerveau isolé, cerveau in the sense of cerebrum in French, not necessarily brain. And so this is one of the first set of experiments that told us that there's something in here, in this region of the brainstem, which is where the arousal centers sit. And so now we have detailed information about that. But this is some of the first one of the first experiments that gave us insight into this. And what I want to point out is that every anesthetic has a target down here in the brainstem, and slow oscillations are one of the things you're going to see, but they're different mechanistically. They're not the same. All right. So just to make this more sort of more realistic, actually, audience poll. So how many people have had anesthesia? Yeah, see, it's a very timely topic, right. So what I'm going to do is I'm going to show you give you a sense of what this is like. So this is a EEG. We can put 4 leads of EEG on all of our patients as we take care of them under anesthesia. And so this is a woman that I'm about to induce into anesthesia. She is about 60 years old. She weighs about 80 kilos. And I'm going to give her a bolus dose of propofol, 150 milligrams of propofol, all right? And I'm just going to play the video, and I'll just talk you through it. All right. So the first thing you're going to see is it's going to get noisy. All 4 leads are going to get noisy. And they're going to get noisy because when you inject propofol into like a small vein, like the one on the back of my hand, it burns like crazy. So you see that noise there? That's her doing this. She's tensing up. This is very typical. We're saying just bear with us for a second. And what happens is this is actually going to be good from a pedagogical standpoint because you're going to be able to see exactly when the drugs take their effect. So you can see she's still fighting the stinging. But watch what happens right here. Right there. Look at that. Beta oscillations. Deeper, slow oscillations, slow delta oscillations. Even deeper. And watch this. She's going to go flat. And then burst. And then flat. And burst. Right? So what am I showing you? So I just showed you this. So this is her awake. You saw the oscillations were like low amplitude and basically high frequency. So she's awake. So these are what we would call gamma oscillations. Is where our brain usually sort of processes information. And then when the propofol took effect, you saw her appear in this stage here, these sort of what we call beta oscillations, somewhere just above 14 hertz or so, 14 to maybe 18 hertz or so. And if I wanted to give her anesthesia so that she could have like a colonoscopy or something like that, I would just titrate the propofol to the state there. She would be somewhat arousable. She'd be able to talk to me at the same time. She wouldn't be fully unconscious. But then what we saw was she jumped right to this state here. She hopped over D. She went right to E. And she had these large, slow oscillations. And right then, that's when so if we apply Bremé's idea, that's probably when we're having the effect on the brainstem. Now, the drug is actually getting to the cortex, probably the thalamus, probably at the same time it's getting to the brainstem. But the reason I know that this E is actually at the brainstem is that if at the time when the slow oscillations came on, I did one of my little clinical neuro exams and checked her oculocephalic reflex, her eyes would be fixed in the midline. It's also when she stopped breathing, again suggesting that there's a brainstem effect. So that's when Bremé's principle sort of came into play right there with her. And then she went into burst suppression, and in between the bursts she was flat. So all of these are states of unconsciousness that we see under anesthesia. What we try to get you to is just here, where you just have the slow oscillation like this, and then a higher frequency oscillation riding on top. This is with propofol, which is at about 10 cycles per second. That's where we want to be. But you see, even I overshot. I gave her a dose. She went all the way down, and now she'll sort of like gradually come back up. Fortunately, I know that because I'm using the EEG to track her brain states, which is something which isn't sort of standard practice. There's no requirement for us to do that. So let's take a look at this sort of anesthetic by anesthetic. So we've been talking about propofol. So this is a spectrogram of propofol. So in this case, this was a young woman I took care of a few years back who was having a small procedure, and she needed to be sort of anesthetized for about 30 minutes or so. So this is a spectrogram. So time on this axis, frequency on this axis, and the colors basically code the magnitude of the oscillations that we're seeing. So you can see we start the propofol here. She has initially a lot of movement artifact, but then it goes away, and you have this slow delta oscillation between about 0.1 and about 4 hertz, and something around 10 hertz here. And that what you're seeing here, just to go back here, what you're seeing here is this oscillation here. You're seeing D. All right. See how it has a high frequency part and has a low frequency part. And that's what you're seeing here. And as long as you keep the propofol infusion running, you maintain her in that state. You turn it off, and over here she wakes up. So that's what you can see in the operating room. I can draw some diagrams and talk about how this actually is acting in the brain. And so propofol works by enhancing GABAergic inhibition. And so GABAergic interneurons are everywhere throughout the central nervous system. But I just want to point out 3 important sites. One is right here in the cortex, where there are a lot of inhibitory interneurons. Also here in the reticular thalamus, which controls, sort of all the input, all the output leading from the thalamus going up to the cortex. And also down here in this area here, the preoptic area, the hypothalamus. This is probably one of the main areas that was inactivated. At least the projections onto these arousal centers was inactivated through these projections coming from the preoptic area of the hypothalamus. So the preoptic area of the hypothalamus is like my wrist, all right? And it sends inhibitory projections onto each of those arousal centers, the ones that I was pointing to, and they're GABAergic. So propofol comes up through the basilar artery, hits these arousal centers, and goes, oh, well, thank you, thank you, thank you, thank you, and just takes them all out, just like that, all right? So that's when you saw those large, slow oscillations appear on the screen. That was part of what was happening. It's also getting those other areas too. Don't misunderstand me. But that was probably what was occurring there. So this is consistent with Bremé's principle for propofol. You can see that there are these large why these large slow oscillations have come about. And just to push this a bit further, so we've done these experiments in humans as well as in non-human primates. So patients come to have epilepsy surgery who have intractable epilepsy, and they get grids and strips implanted, like the ones I'm showing over here, and they stay in the hospital for like off medications for 5 to 7 days. Once they've seized enough, and we have a good idea of what the seizure focus is, I should say the care team has a good idea where the seizure focus is, they come back to the operating room to have the electrodes removed and then eventually have a resection. But if you look right here, so if you think about what's going on, you have this really nice natural experiment. You have a human that has electrodes in his or her brain, and you're going to give them propofol, so you can just record and just find out what human neurons do in response to propofol. And this is from Laura Lewis's PhD thesis. And so the color codes here correspond to the locations here on the medial temporal lobe we're recording. And this is a neuron which is sitting next to the red electrode right here. So this is the person awake. And now look what happens here. Once they're unconscious, you just have slow oscillation. Slow oscillation. So about roughly every 2 seconds or so. And so you can see here the neuron could spike where we wanted to, and now this neuron is only spiking here at these locations. So I don't know how much the rate has to be dropped in order for you to become unconscious. What I would submit to you, if this is happening all across the brain, it's going to be very difficult for someone to maintain consciousness. So you can see how the slow oscillation can be associated with in this case, this person being unconscious. But we pushed a little bit further in the last few years or so, thanks to my collaboration with Earl Miller at MIT and also his postdoc Andre Bastos and Jake Donahue, who I mentioned before, a PhD student. We repeated the same experiments in non-human primates. And so these are 4 brain areas up here. This is area 8A, so this is the frontal eye fields, the prefrontal cortex, and 2 posterior regions, the posterior parietal cortex and superior temporal gyrus. And then down here are the neurons spiking at those locations, all right? Over here, this is when the animal's awake, and here the animal's unconscious. So the first thing over here, you see the very low frequency, the very high frequency oscillation, low amplitude, and here you see the neurons spiking pretty much wherever they want to. So just to quantify this a bit, they're spiking about 10 spikes per second, right? That's the rate. Now look what happens here when they're here, the slow oscillations, just like we saw with the patient there just a second ago, slow oscillations. And now you can see that when the slow oscillations here are occurring, you're having these huge up-down states. You have a little bit of spiking, no spiking, a little bit of spiking, sort of no spiking. And in fact, the spike rates are quite different. Here they're 10 spikes per second, here they're 1/2 to 1 spike per second. So they drop by as much as 90% essentially. And again, I can't tell you how far down it has to drop, or what's the threshold you have to cross in order to be unconscious. But I submit to you, this monkey is profoundly unconscious in the state here. He is not doing calculus right now. All right. So, and the reason I keep emphasizing this is because of this. You can see this in the operating room. This is my point. Here it is. This is the corresponding thing you can see in the operating room. So with these sort of slow oscillations here from propofol or other GABAergic anesthetics like sevoflurane, isoflurane, and desflurane, just to remind you, they're also ethers, or the barbiturates, you would see these sorts of oscillations. And if you saw these oscillations like this generated by one of these drugs, you know the person's unconscious. So you can actually see this in real time. And this is not some embellished graph or what have you. The oscillations look just as clear on the monitor in the operating room. So let's talk about ketamine, a little bit different. As you know, ketamine is being used widely for a number of things, now in particular for treating depression. And so this is research which was done by my PhD student Andy Garwood and Suresh Chakrabarty, who I mentioned before, one of my former postdocs. And ketamine is really interesting because when you give a low dose of ketamine, instead of the EEG slowing down, it actually speeds up, right? And part of that mechanism has to do with the fact that it has to get into the channels in order to create its blockade of the NMDA receptors, which you'd think it would actually slow things down. But it actually has a preference at low doses for inhibitory interneurons. So what's happening is it's taking out the inhibitory interneurons. Pyramidal neurons are released, and so they become active. So you see something like this. And then once enough of them have sort of become active, they feed back onto the interneurons, and you get a slowing. So what's really cool about propofol, once you give at a low dose, you'll get something like this, but once you give a dose which is sufficient enough to induce general anesthesia alone, you'll see the high frequency, slow, high frequency, slow. It goes back and forth like this every 4 to 10 seconds or so. And ketamine is really important because the World Health Organization has classified it as an essential drug. If you had to go to some remote area to give anesthesia care and you can only take one drug with you, you would take ketamine because it can make you unconscious as well as it gives you very profound analgesia. Propofol won't do that. Propofol can make you unconscious, but it doesn't control analgesia at all, right? And so again, just applying Bremé's principle, we might think that there would be areas in the brainstem which would be responsible for this, and sure enough, these NMDA pathways, these NMDA pathways here coming out of the medial-pontine reticular formation and the parabrachial nucleus are probably areas, some of the areas where the ketamine, is actually having its effect. But it's a little more complicated than that. I just wanted to show you this. So it doesn't, when someone's under ketamine anesthesia, it just doesn't go fast, slow, fast, slow. Actually, there's a series of stages that it goes through. And Andy looked at this. So again, we looked at this in the non-human primates. And so here you can see there are the fast oscillations, and there are the interspace sort of slower oscillations. And when you blow this up a little bit, you see how it goes. There's the fast piece, slow piece, fast piece, slow piece. And then right here, we actually, or I should say Indy, built a model of this, a hidden Markov model, which we show there are basically about 4 or 5 states that you actually go through. So the person starts slow, speeds up a little bit more, speeds up, and back to the slow state, speeds up, speeds up, speeds up. So it's actually doing this, going through a series of states. This is also unconsciousness, right? It's an unconsciousness which is actually different from the one we saw for propofol. And in fact, the neurons in this particular case, the spike rates are on average the same as they are when the person's awake. But the neural dynamics are just different, all right? So you can be, so in other words, so again, making the point that just because you see a certain oscillation doesn't mean the brain is in the same state. And I mean, as neuroscientists are well aware of this, but people often think all anesthetics work the same way. And this is working quite differently. And one of the things that Indy pointed out was she looked at the degree to which there was synchrony across the 4 regions where she was recording. So she found that about 50% of the time, all 4 areas where she was recording from, the 2 frontal areas here and the two more posterior areas are in sync about 50% of the time. About 70% of the time, the 2 posterior areas are in sync. And about 80% of the time, the 2 frontal areas are in sync. So the architecture you've created is a brain which is, instead of being highly flexible and with sort of low amplitude oscillations, to being highly structured and rigid. And again, another dynamic which is going to prevent you from transmitting information, again, would contribute to someone being unconscious. So I had to put this in there. So Ezra Marcus is a writer for the New York Times who called me up a couple of years ago because he was going to write this article on nitrous oxide because he said there's been a resurgence in the interest of people sniffing nitrous oxide to get high and for having fun. Okay, this is dumb. Do not do this, all right? All right? All right? And just to put it into context, so when I see him there with that nitrous oxide mask over his nose like this, we actually do in anesthesia what's called a single breath induction, where we can get people to take one deep breath of the anesthetics and be completely out. Like sometimes I had a woman who, if you went to try to put an IV in her, she would get hives. She just couldn't stand the idea of a needle. So we did a single breath induction with her, exactly what he's doing there. And we do this all the time with little kids where we can't put in IVs. So when I see him anesthetizing himself like that, that's what comes to my mind, him knocking himself out and not being able to come to. But what he was interested in was what I had written in this article. Nitrous oxide, we still use it. And we analyzed about 19 cases of nitrous oxide we had used over a period of about 2 years. And we saw these very interesting patterns. This is your brain on nitrous oxide. It looks like perfect sine waves. All right. So this is each one of these vertical lines here, like here and here. Each one of those is 1 second. So this has basically 2 cycles per second. Perfect 2 cycles per second. I mean, there's no noise or anything. This is what your brain is doing on nitrous oxide. So you can see, again, this is a state which is probably not very compatible with being conscious. But not only that, it could be very compatible with turning your respiratory system off as well. All right. So that's why I said do not do this. All right. And again, just applying Bremé's principle, it suggests that there are targets down here in the brainstem where they could be acting. And again, we think that these NMDA receptors, the parabrachial nucleus and the medial pontine reticular formation, play a role. And the way we do this in the operating room is you're on another anesthetic. Let's say you're on isoflurane. And the reason we switch over to nitrous oxide is it's easier to wake patients up for nitrous oxide compared to, let's say, isoflurane, sevoflurane. So you can see it right here. So here's the spectrogram. The person on isoflurane, they started the nitrous oxide here. So slowly these oscillations break up, And they're the large slow oscillations like I was showing you. This is what one of them looks like blown up here. And what's really wild about this is they don't stay. They disappear after a bit. They stay for about maybe as long as 15 minutes or so. Then they disappear and they go to high frequency. So we have no idea why that occurs. And it's probably something I'm not going to investigate further because nitrous oxide is not a friend to the environment. And just one final example here, dexmedetomidine. So people often ask me, are any of your anesthetics, do they do anything which comes anywhere close to what happens during sleep? And the anesthetic that does that is actually dexmedetomidine. So it's if you give a low dose of dexmedetomidine, you can actually see features that look just like non-REM stage 2 sleep, like the spindles, like I'm showing you here, or you can see them here in the time domain. Or if you give a deeper dose, you can get just pure slow waves like you see in slow wave sleep. And part of this has to do with the fact that this drug, when it shuts off the brain in a way which is consistent, one of the ways in which sleep begins. So here, if you look here, again, going back to the brainstem, here's this area called the locus coeruleus. The locus coeruleus has a lot of important projections into the central thalamus. It projects to the preoptic area of the hypothalamus. It projects to the basal forebrain, and it projects directly to the cortex. And all that's sort of adrenergic excitation. So what it's doing is, when you give dexmedetomidine, you're just basically pulling away this excitation from the cortex. And actually, this is probably one of the cleanest ways in order to induce unconsciousness. You're not just sort of going directly, creating local oscillatory circuits directly in the cortex or what have you. You're just pulling away inputs. And then, again, teleologically, it's not surprising this is part of one of the ways in which, we fall off to sleep. And as consistent with this now is we've used this for a while for sedation in the ICU and also as an adjunct in the operating room. And a sublingual version of this just came out for use in the hospital. We just got on a formulary a couple weeks ago. So you'll probably be seeing this as a sleeping medication on the market in a very short period of time. Of course, I have no financial interest in it, just in the spirit of full disclosure. So just 3 other little factoids. Who else has slow oscillations? Very young kids. If you anesthetize a young child between the ages of 0 to 3 months of age with sevoflurane, one of the GABAergic drugs, they just have slow oscillations. Something magical happens at 4 months. At 4 months, you start to see the alpha oscillations appear. And we think it's because the thalamocortical loops really haven't matured enough to generate the alpha oscillations. Older patients, and older is in quotation marks because it just depends upon how old your brain is. As we get older, we don't produce the alpha oscillations anymore. And there, what may be happening is there's degeneration of the connections between the thalamus and the cortex. And this is a case which is really a case where we typically see it in patients coming down from the ICU. This is a gentleman who was a drug addict who was shooting up, and he got a necrotizing infection on his arm. So he had to come back to the operating room every 3 or 4 days to have it debrided. And I asked the nurses before I took him down, I said, how awake is he? She said, well, yeah, plus minus. They hadn't used the EEG on him in the ICU, and so when I put the EEG on it, I thought it wasn't working. All you just saw was just these slow oscillations. Then I've come to realize since then that this is a very typical pattern for patients in the ICU, particularly those that have infections. You see these large sort of slow oscillations. And we saw this a lot during COVID. And there's some good biology behind this. First of all, just sort of in a hand-waving sense, once you get a cold or something like that, you don't feel like running a marathon. You start to feel sleepy, you want to rest. And Mark Ott at Washington University the University of Washington in Seattle showed a couple years ago that the inflammatory mediators bind to those brainstem sites that I was pointing to before and actually sort of turns them off. So the inflammation actually turns off the arousal centers. And so one of the things I always wondered was, once this guy's sepsis cleared up, would his alpha oscillations come back? All right. So we just got data on that in the last year or so, again, in a COVID patient. So this is work put together by Christian Gay, who's one of our cardiac and ICU fellows. This is a patient he took care of who has this massive, massive pneumonia. You can see here on day 0 and day 1 from COVID. And this is his EEG. He basically has no alpha oscillations. And so look, his lungs clear up day 2, even better on day 3. His alpha oscillations are back, all right? I mean, not proof, but just showing a clinical correlate, the idea that inflammation can often play a very large role in our brain states. And in this case, contributes to the production of the slow oscillations. So 2 other factoids. So the anesthesia patterns change dramatically with age. Let me just show you this. So over here is a 30-year-old, like the young woman I showed you before, alpha oscillations, slow delta oscillations with propofol. Here's someone who's 57, all right? You can see the alpha oscillation there. Maybe it's a little bit weaker, maybe the frequency shifted down, but it's still there. Here's the slow delta oscillation. And then here's a woman who's 81 years old, right? You can barely see any alpha oscillations whatsoever. She's like the 78-year-old gentleman I showed you earlier. And you can see her slow oscillations are actually quite weak. This is a woman who had a tumor on her chest the size of an American football. It took the thoracic surgeons the better part of 6 hours to remove it. And I was able to keep her appropriately anesthetized just by giving her what was 1/3 of the already age-adjusted dose of propofol, because I was watching the EEG the whole time and just adjusting it as needed be. Otherwise, she probably would have been grossly overdosed. Here's the part that's a little bit sobering. These 2 guys are the same age. His EEG looks like hers. His EEG looks like his. And, you know, we age different. Physically, it makes sense that our brains probably age differently as well. And, you know, and what's wild is you can see this under anesthesia. It kind of reminds me of this old Clairol hair color commercial from the 50s and from the 60s and 70s, where they'd say, maybe only your hairdresser knows for sure. Well, maybe only anesthesiologist knows for sure, like, you know, how old you really are, right? And then you can just see this. Here are the kids, like the 3-year-old, the 14-year-old. I mean, again, like I said, these are not embellished graphs. It looks just like this in the operating room. And you can see that all the power that's across it's the same pattern, but it's over a much broader range. And it turns out that the maximum power that you'll see is somewhere between 6 to 8 years of age. And so I know we've been talking about these people here going downhill, but those of you out there in your 20s, you're going downhill too, because your peak was actually several years ago, so don't get too smug about this. But the point is that the dynamics change dramatically with age, and this is something which we can be aware of and take into account as we take care of patients, but it's also telling us something about the physiology of the brain at the same time. And this is probably one of the most important things I want to tell you. General anesthesia is not sleep, all right? So, as we know, sleep is the state you go through, non-REM, 2, 3, then back up to REM. You do that every 90 minutes or so. You do it about 4 to 6 times a night. And you probably wake up from a REM episode, because that's when you're dreaming, or you often have micro arousals around those times. Anesthesia is quite different. What we do is we hold you in a state like this for several hours, just basically like this, and what I call pathologic oscillations, which are making it difficult for your brain to communicate. And so once you realize this, the whole thing with Michael Jackson trying to use, propofol to try to sleep really made no sense whatsoever. I mean, it's just really very, very, extremely dangerous, as we essentially saw, because it's not producing a sleep-like state. It's actually producing a sedative state, essentially. And in fact, I can go even further than that. If you look at, as I said, dexmedetomidine is the one, and it hasn't even made it to the market. It's the one sleeping medication which acts more the way sleep is actually really induced. All the other approaches, really, if you call them weak anesthetics or sedatives as opposed to sleeping medications, it's actually a more accurate statement about what they're doing. Because the idea is that maybe they can sedate you, and then your natural sleeping mechanisms will then take over. But they themselves are not producing this REM, non-REM. All right, I think that's important to understand. All right, so multimodal general anesthesia. This is my colleague Manu Naranjo, who's this brilliant anesthesiologist in Merida in the Yucatan Peninsula in Mexico, who really has some very clever ideas about practicing anesthesia using neuroscience, which she and I have collaborated on. And so, and one of them is multimodal anesthesia. So what do we do now? We have what we call balanced general anesthesia. We have the drugs which we use to induce unconsciousness, We'll give you a little opioid to control your pain, your nociception. We don't do anything explicitly for amnesia because we think if you're sufficiently unconscious, you'll be amnestic. And we give you medications to relax your muscles to induce immobility, essentially, to make it easier for the surgeons to operate. And that's just, there's no specific logic as to how this is done. This is just a practice that we've done over many years. But with multimodal general anesthesia, the idea that Marusa and I put forward is that what you should do is pick, you need anesthesia because surgery hurts. So what you should do is pick multiple drugs to control the pain pathways or the nociceptive pathways, all right? So if you do that, they're going to reduce the amount of drug you need to make you unconscious. You'll have to monitor unconsciousness somehow. We'll use the EEG, we'll monitor nociception or anti-nociception by looking at the heart rate and blood pressure. And you should continue the same strategy in the postoperative period. I'll just show you one example of this. So this is a woman I took care of about 4 years ago. She's 89 plus, so you may not be aware of this, but HIPAA doesn't allow you to give someone's age who's over 89. All right, so let's just say she had a lot of pluses after her 89. All right. And she had a history of diabetes, hypertension. She was having a laparoscopic right colectomy. She's about 5 feet tall. She weighs about 57 kilos. So I used 3 medications over here, dexmedetomidine, remifentanil, and lidocaine to control nociception, to control her pain, basically, during the surgery. And I gave her propofol to keep her unconscious. Now, this may not mean anything to you, but 30 micrograms per kilogram per minute of propofol is a homeopathic dose. I mean, it's just like sniffing it, basically. I mean, it had absolutely no effect on most of the people in this room. But this turns out all that she needed, essentially. And again, we realized this because we were actually titrating it to the EEG. And so this is her EEG. You can see she just has slow oscillations here. Again, she's an older person, that's what we'd expect. Her vital signs are quite stable. You can see the slow oscillations here on the EEG there. So, and the one thing about this is that when people come to after this approach to anesthesia, their heads tend to be very clear. We haven't done a clinical trial on that, and this is just me speaking from my clinical experience, but this is something we're going to investigate in cardiac surgery at the BI hospital starting in the fall. And this is just an overview of the idea. So all the drugs that we're using, the opioid, dexmedetomidine, they have effect on arousal in addition to their analgesic effects. So that means propofol, you can get you can allow propofol to have its effect by using less, essentially. That's the idea. All right. So 2 final things: closed loop control of anesthesia and reanimation. And if we properly trained a computer, it should be able to watch the brain more reliably than a person could, and sort of help you dose the drugs. So this is something we've been working on for a bit. And we built a system about 10 years ago in mice. It was very successful in controlling the anesthetic state. And we took it to the FDA and they said, well, Emery, this is really cute, but you've got to do it in animals that are closer to humans. So we set out to build a system for non-human primates. And so the principles are straightforward. This is just a standard closed-loop control system. And so you have a target that you set, and then you measure what that target is from the brain. In this case, we're measuring from the local field potentials. It goes into the controller. The difference between where you are and where you want to be changes the infusion rate of the pump going into the propofol going to the monkey. And every 20 seconds, it basically updates the infusion. So it's just a very standard control setup, nothing fancy. And so, but this is the part of the neuroscience that really made this work. So let me just show you. Remember, you give propofol, a constant infusion of it. Remember how I showed you that the spike rates went really low? They went down. At the same time, it turns out that the power in the 20 to 30 hertz band also goes down as well. So if you're watching this guy go down when you're giving propofol, it means what you're doing is actually you're controlling this. So this is a great marker to know that this is happening, because this, the animals were profoundly unconscious, the people were profoundly unconscious when they had very low spike rates. So we're going to control the power in the 20 to 30 hertz band. That's going to be our marker. All right. So just to show you this in a little video. So Suresh normalized the marker so it should be at 1. And what he's going to do first is just let the infusion pump run, because that's what we do in the operating room now. We just let it run at a constant rate, and we'll see what it does. And then about 40 minutes in or 30 minutes in, he's going to let the controller take over. So let me just show you this. So there's the marker here, and this is the infusion rate. It's constant. You can see it's being held constant at 0.4. And the marker is wandering all over the place, up here in the upper panel. Up here. Oops, sorry. Let's start that again. I swear it's the same marker. So it's running, it's going all over the place. And now watch what happens when the controller takes over. So the controller takes over now. Now it locks it at 1. It holds it at 1 where you want it to be. And so now we're going to take it, I think it takes it even deeper here. So take it down a level below 1. So it goes down, no problem. Then the next thing he's going to do is take it above 1. And he's holding each state for about 40 minutes or so, 35 minutes. And so what I want to point out to you, the key part, which is actually very clinically relevant, is the following. Look right over here. This is the operating room. This is what we do now. We run constant infusions. And what's happening to most people, they're just getting deeper and deeper and deeper and deeper. Look what the controller did. It actually shut off for about 3 minutes so it could get back up to the target where it wanted to be, right? And then it held the marker where it wanted to be. And the same thing over here. It actually shut off for 8 minutes over here to get back on track. So it's pretty clear that we could do something, much better than just managing it. Because there's no way in the world that I'm going to look every 20 seconds to actually update, to update the control of my patient's level of unconsciousness. All right. So if we're monitoring, we're using closed-loop control, then the final thing we should do is wake you up after anesthesia. We should give you something to turn your brain back on. So this is research that's been done for a while now by my colleague Ken Salt. So this is one of the rat volunteers in his laboratory who has propofol running into his tail vein. See the white? It's right here. This is propofol running into his tail vein. He's anesthetized with propofol. And Ken has an electrode going at this animal's VTA, his ventral tegmental area. And what he's going to do is, in just a second, he's not going to turn the propofol off. He's going to stimulate this guy's VTA. And watch right here. See, turn the stimulation on. Look how he starts breathing like crazy. The propofol isn't turned off. And he hops up and says, look, I'm out of here. All right, he's gone. All right. So he's gone, but is he conscious? And can he really process? So Ken did another set of experiments right here in which he has a rat that he trained to execute a task. So he touches the correct light and he gets a reward. So now he anesthetizes him and he has an electrode in the same location. So what he's going to do is the animal's anesthetized there. He's going to wake him up. And when he wakes up, he's going to start performing the task, right? So he's going to turn the stimulation on. It's overcome the anesthesia, so he's awake. And he's consciously processing. He looks for a reward, but he doesn't get one. He has to hit the left side. So he hits the light there. Now he gets a reward. Turns around again. Turns around again. Hits the correct light. So the point is he's cognitively processing it. He's not just awake, but he's back cognitively as well. All right. And now what's going to happen is I think he's going to do this one more time. I think he gets the next one wrong. Yeah, he got that. So the light tells him it was wrong. All right, so no reward. So now he turns around one final time. Remember, the isoflurane has still been on this whole time, and he's just been stimulating his VTA. Now he turns around. He turns the stimulation off, and the rat is out. All right? So he was only awake because we were driving his VTA. So the idea that we can maybe precisely control brain states is something that we want to investigate in a lot of detail. I think it's very feasible. So what is Ken doing? He's stimulating this part of the brain right here, the ventral tegmental area. It's the origin of the mesocortical pathway going through the limbic system up to the cortex. And another way that he's also done this is by giving Ritalin, which acts in this pathway. And maybe the clinical way, one of the clinical ways we actually end up doing this, but he's done this electrically like I just showed you, but he's also done it optogenetically, getting specifically D1 neurons, turning them on and waking up this pathway here. So this is something which we're translating into clinical trials now. So So what have I shown you? So the slow delta oscillations are produced by all the anesthetics, but for different mechanisms. Acting directly in the brainstem, probably hyperpolarizing the cortex and thalamic regions as well. Each anesthetic has a different signature. It depends upon its mechanism of action. They change with dose, patient age, and physiological condition. And they provide markers that we could use to build closed-loop systems. And I showed you multimodal anesthesia, which is a way in which we could have more, using the current drugs much better to control nociception, maybe reduce sort of brain effects of the anesthetics. Elderly patients, particularly, have a lot of problems after anesthesia cognitively. And this may be one of the ways, if we have no new techniques for just using the current techniques, current drugs better. And reanimation, we should definitely do something to turn the brain back on, because let me say it this way, there's no reason not to, and there are probably a lot of safe ways of doing it. So I'll just leave you with this one slide. So this is the field of general anesthesia. You know, it's not viewed as a part of clinical neuroscience, but actually is intimately, you know, there's the New Yorker's view of the world where New York is in the center and the rest of the world. So this is an anesthesiologist's view of clinical neuroscience. There we are in the center, and the rest of the neuroscience revolves around us, you know. But there are these amazing connections to all these areas. I mean, you're aware of like using ketamine, as I said, to treat depression. But actually with epilepsy, intractable epilepsy, the ultimate therapy is actually general anesthesia. But also if the surgeon is looking for an epileptic focus in the operating room, giving low doses of methotrexate, which can be an anti-seizure medication, to actually induce seizures is what's often done. And we know that, I mentioned sleep already, and that same idea that we're using to turn the brain back on for anesthesia, we're looking at to do it for coma recovery. So the point is that we can only make these connections if we take anesthesia seriously as a discipline of clinical neuroscience, just like neurology, neurosurgery, psychiatry, and sleep medicine. And the people who are losing out because we're not doing that are basically our patients, but also we can contribute to some of these other fields, and other fields contribute to what we're doing if we make this link. So that's something which we've been trying to push forward for, and hopefully we'll be able to succeed. So, thank you.
This working? Yeah. So we have time for questions, if anyone has any. Oh, there's one.
I may have missed it. Great talk, by the way.
Thank you.
For the sepsis patient, you said that they were also a drug addict?
Yeah. Mm-hmm.
And did that, did you guys ever see, any effect of the alpha wave disappearing because of the effect of the drug? Not necessarily, because that was under anesthesia, right, that graph?
Right, exactly. Both those were under anesthesia. So I've taken care of other drug addicts, and I've seen alpha oscillations in them. So and again, this wasn't any sort of controlled study, or this is just a lot of anecdotal information or clinical observations. But to me, the most compelling one is the patient with COVID, where you actually see his alpha oscillations come back once the COVID clears up. And so again, consistent with the idea. And so these are attempts to try to make some robust clinical observations we can now go and investigate in the basic science sense. And I'm pretty confident about this with the alpha oscillation and the inflammation. Question?
It's a great talk.
Thanks, Dan.
You talked a lot today about slow waves. Can you comment on what you think the origin of slow waves is? Because they're not only slow, but they're also highly synchronized. So where do you think all the synchrony is coming from?
I mean, that's a really good question. We've done some modeling work on it to try to, it's work we've been doing with like Nancy Capel at Boston University. I think that one of the components of it, is that in all the cases, the one thing that all these things have in common, if we go back here, the one thing that all these things have in common is that they're taking away inputs that are coming out of this part of the brain. All the anesthetics are. So you're pulling away excitatory inputs which are going to cortex, thalamus, and what have you. And in that case, what's very interesting though is that the time scale that all of them end up on is somewhere around 1 to 2 hertz, or maybe as high as 4 hertz. So the why of that, I don't know. But what's associated with that is the hyperpolarization of those cortical neurons. That's what the pyramidal neurons in the cortex, that they come together on a time scale of about slow oscillation 2 hertz or so. I mean, that's what we've seen. So we're trying to sort of sort this out now with some modeling work. I think in another year or so we'll have probably a little clearer answer. But that's what I think is going on now.
Okay. When asked to these preparations, the primary preparations, is that also the cerebellum is cut off from the cortex?
Sure.
Not only the stuff, the brainstem.
For sure.
So, do you think the cerebellum also contributes in some effect, some of these effects?
I'm sure it does. I just have to plead ignorance because we just haven't studied it in the detail you might expect. We know the cerebellum does a lot more things. Actually, the cerebellum plays an important role in arousal control because one of the, you think that you're going to see some sort of maybe movement disorders if you have a cerebellum lesion, but like sometimes with cerebral strokes, you actually cognitive function, which is actually impaired, more so than necessarily some sort of motor function. So to that, because there's some very rich projections which come out of the cerebellum going directly into the thalamus, and also cerebellum going directly into the cortex. So it's definitely played a role, and you're right. We skipped over that. So, but I think you're completely right. It definitely is probably playing a role.
Hi, thanks so much for your talk. You mentioned that ketamine could be potentially used to treat depression. I was wondering if you've seen any differences in the brain activity under anesthesia or the response to the drugs for people who have like major depression or anxiety disorders or PTSD, things like that.
Not in the sense I think you mean, but and let me just be clear. So ketamine is actually approved for treatment of depression. It's actually a recognized therapy now, and delivered either intravenously or intranasally. So it's basically on the formularies for that. I can't say I've seen anything which I can necessarily relate to the depression, but one of the things that was the reason the idea behind ketamine being used for depression came into being was that John Crystal, who's a very well-known neurologist psychiatrist at Yale, was testing out psychedelics on patients in the late 1990s and the early 2000s. And one of the things he did was he noticed that one of his patients who had gotten ketamine, who had depression, had gotten better. So he started trying out ketamine. So he did a study which they published in the year 2000, basically showing that there was an effect, a positive effect on, or helping of ketamine as an antidepressant in 2000. And Carlos Zarate came along in 2006 and repeated it in a formal clinical trial to basically show that. So ketamine actually does work. It worked. And there was just a large trial that was published a few months ago in the New England Journal sort of reinforcing that idea. And what's also very interesting about this, I didn't mention, it turns out that there's evidence that each one of the anesthetics I've discussed here could be used to treat depression. Propofol, isoflurane, dexmedetomidine for postpartum depression. So there's something there, which there may be a whole other role for these drugs that we haven't even scratched the surface of. So I think there are a lot of possibilities there as well.
Any other questions?
So you talked about how anesthesia and sleep can be intimately related. Have you seen?
No, they're not, really. They're like this.
You studied the effects of different drugs on sleep. Have you seen any difference based on the time in the circadian cycle that you administer?
No, I haven't done any circadian studies, but that's something that our ICU folks are trying to think more about. It's a very challenging thing to do, though, and and just to be technically precise, it's probably not circadian effects, because circadian effects means that you're actually seeing the intrinsic period of the circadian clock running on its own. It's probably diurnal effects. It means, differences between day and night. Not to say a component of that isn't the circadian piece, but I mean just to be precise in the vocabulary. I think that there's something there, but that's a very hard problem to sort out. Extremely hard, because one of the things that we often do. However, there's a group at the Charity Hospital in Berlin, which has shown that when they've been able to sort of create more normal day-night cycles for patients, it helps patients in the ICU recover faster. So there is some suggestion that could benefit.
Okay.
Yeah, so there was an observation made where alpha oscillations returned with COVID recovery. In your opinion, is the reverse?
I'm sorry, what was that?
The alpha oscillations returned with COVID recovery.
Right.
So in your opinion, is the reverse possible where you simulate alpha oscillations which leads to certain recovery?
Simulate alpha oscillations leading to recovery. In other words, could I work through the alpha oscillations? You mean?
Yeah, like simulate alpha oscillations in the brain.
No. What I think was happening there is, so one of the things you could see from his X-ray, right? If you look at this guy's chest X-ray, just to show you real quick. There it is. He's got, both of his lungs are basically filled with pneumonia, basically. He's got total body sepsis. He's got inflammation everywhere. And the thing that happens when you go to days 2 and 3 is that you're clearing up the inflammation. There's some reduction in it. And I think it's that reduction in inflammation, the inhibitory effects that are being had at the brainstem, which is being reduced, which is allowing him to come back. I think that's contributory. That's what I was postulating.
Any other questions? If not, I'll ask the last question.
Okay.
So I wanted to ask about the patients who didn't have alpha and therefore needed less anesthetic. I didn't quite understand the mechanism there. Why is the lack of alpha meaning they need less anesthetic?
So what I think we've come to see empirically, and this has been documented by a number of different groups, is that the lack of alpha oscillations is a suggestion of brain fragility. And there have been there are at least 2 studies that I know where they show that people with weaker alpha oscillations were more likely to have postoperative delirium. And now the actual why of that, our research has shown, both modeling research and experimental research has shown that the alpha oscillation is an oscillation going back between the thalamus and cortex. And so maybe it's telling us something about the thalamocortical connectivity and integrity. Its integrity, indirectly. That would be my guess right now if you tried to pin me down. But that's why it indicates that.
All right. Thank you, Dr. Brown.
Thank you. Thanks for.